Good evening, everyone, and thank you for joining us for tonight's clinical webcast, utilizing the Pentacam in the total refractive practice. Before we get started, I'd like to point out that you have a questions box on the right side of the screen, and I encourage you to leave questions or comments there, and we will conclude tonight's presentation with a short Q&A. It's a pleasure to introduce tonight's speaker, Dr. David Hardten. Dr. Hardten is co-founder of one of the nation's leading eye institutes for patient care as well as research and education, Minnesota Eye Consultants. Dr. Hardten has numerous publications in ophthalmology journals and has received several awards for his work over the years, including a Casbeer Award for Outstanding Contribution to the Research and Development of Refractive Surgery from the International Society of Refractive Surgery, and the Ophthalmologist Continuing Education Award from the American Academy of Ophthalmology. It's an honor to have Dr. Hardten here to share some of his insights and clinical pearls on the OCULUS Pentacam. So without further delay, I'd like to welcome Dr. David Hardten.
Thanks, Chris, and good evening. I appreciate you joining us here tonight. We're going to talk about the OCULUS Pentacam for refractive surgery practice and really for the comprehensive practice of ophthalmology anterior segment. And so I have done some consulting, researching as is listed there on the slide, and as always, some of the information may not necessarily be approved by the FDA. So in your practice, the most common use of topography, tomography, etc., will probably be keratoconus screening when you're talking about refractive surgery. So one of the first things I'll talk about for use of the OCULUS Pentacam is that in refractive surgery. And really what we're looking for when we're doing refractive surgery screening is trying to decide, does this patient have keratoconus? Are they at risk for ectasia? And is it safe to do LASIK? Is it safe to do PRK? Or are we best to avoid refractive surgery in general? We'll talk about also some of the uses in screening for keratoconus when it comes to patients in the cataract surgery age group also as I get a little bit further into the slides. But I want to start first for talking about it mostly with the idea of, can this patient have LASIK? Should I be doing refractive surgery on this patient? Now, I'll point out here, this is a case example of a patient that I saw a couple months ago, came in interested in refractive surgery. And one of the nice things about the Pentacam is that it does give you a lot of different options on trying to look at the whole anterior segment and the cornea, both the anterior surface, the posterior surface, and really gives a lot of sophisticated analysis systems and analysis programs. In this patient here, though, even just looking at this patient and looking at the on the left side over here, looking at the sagittal curvature, you can see there's significant steepness inferiorly with flattening up top, and you can see anterior elevation that's higher than what you would think of just in looking at the color mapping, and also thinning that's slightly displaced from the apex. So in that situation, even if you didn't have very sophisticated tools, you might be able to say, I think I'm going to avoid LASIK in this specific patient. But you also have a little bit more sophisticated tools in that you have a Pachymetric Progression map. For example, here you see that the percentage thickness as it moves from the center to the periphery ends up being such that there's this red line now falls below the typical spread of what would be normal in that situation in a typical normal eye. You also have a variety in these boxes down here of other parameters. And for example, the final D number over here is the one that if it's red, you know, that's the software is telling you, be careful and look and say, okay, is this a patient that maybe you should avoid doing refractive surgery on? And so these are the types of maps that you'll have on the Pentacam, and really trying to understand how you can quickly glance at this material in a refractive surgery patient will be helpful to you. And it takes a little bit more time to kind of get into depth on those maps. But again, the quick aspect of it is you've got front curvature, you've got front elevation, you've got corneal thickness, and you've got back elevation on these variety of maps. And so you should be able to get used to looking at those in your day-to-day refractive surgery practice setting. So the Belin Ambrosio Enhanced Ectasia software package allows early detection of corneal ectasia for these patients that we're screening for refractive surgery. And I showed you the box where the final D is. The final D is a regression analysis of several different indices. So there's basically 9 different indices. And each of those indices is geared towards what would be considered a normal range. So the SD values are less than 1.6. And that'd be considered normal limits. So the box would be white on that bottom right box that I showed you. If they're 1.6 to 3, sort of borderline. So you have to use a little bit more judgment. And over 3, it's abnormal. And so when you're doing these screening examinations with the Pentacam, you can look at the final D in that situation. So I'll go through a few of these with you. So here's the pachymetric progression, the way that the machine looks at pachymetric progression. So for example, you see the thinnest section here, and then basically the typical normal cornea will have a typical progression from the center where it's the thinnest out to the periphery. And so what the pachymetric progression map does is basically looks at this and evaluates the thickness change on these concentric rings from the thinnest spot towards the periphery. And so here's your thinnest spot there in the middle. And as you move out towards the more peripheral areas, then it's basically analyzing that thickness and comparing those thicknesses to the center and to the other areas in the map. So here's a pachymetric progression. The top basically shows the spatial profile, and the bottom is a percentage thickness increase as you move across the graph. And so again, if it falls down into the bottom section here below this typical range here, then that's when you'll be concerned about a patient that might be, for example, have keratoconus. So if you think about keratoconus, the center is thinner than what it normally is, but it's not necessarily that the periphery is thinner than what it should be. So there's a abnormal progression of thinness in the middle to the, or in the center or paracentral area out to the periphery. And so this is a statistical way of analyzing that rather than just having you look and say, well, it looks a little too thin in the middle compared to the periphery, or the apex is slightly displaced, or it's thinner out on the periphery, the back elevation. Again, those are things that are helpful to look at, but having some statistics in a sense around it is very helpful. One of the other maps that's useful is to look at an enhanced reference shape. You probably remember that the best fit sphere is calculated using all the data within the 8 millimeter calculation zone. So for example, here's the values in a sense in reference to a best fit sphere. And so that reference basically, if you take all the points in this 8 millimeter zone and reference them to a sphere, so those areas that are above that sphere that would be the average in a sense of the whole values, the areas that are red are above that best fit sphere. So for example, this area right here is 72 microns above the best fit sphere, whereas these areas are 50 microns below the best fit sphere. And so there's quite a bit of range in that value, plus that anteriorly elevated area away from the best fit sphere is higher. So this basically represents another way of looking at the data to try to figure out, is this patient at risk for keratoconus? Do they have keratoconus? Now and that's the best fit sphere. Now the enhanced reference shape basically calculates only the data outside of this section here that's the steepest. So all the elevation data within that red circle is excluded. And so that basically then can give you a little bit more of an enhancement of the areas that are abnormal. And so again, the typical best fit sphere, you'll see areas above and below. But the new reference shape that basically uses all these others enhances that section that's above that best fit sphere. So that's the enhanced reference shape. So for example, here's a patient that has keratoconus with the viewing with the enhanced reference shape. Basically, you can see here on the anterior elevation, you see sections that are above that best fit sphere or the enhanced best fit sphere. The elevation of the back, and here's the elevation of the back using that enhanced reference. And here, so on the right here are the enhanced reference shapes. On the left are the normal best fit sphere shapes. So basically, you can see that I think this is one you'd still say, oh, I think that's keratoconus because it's more elevated. There's more back elevation than what you'd typically see in a normal eye. Yet the enhanced reference shape basically allows you to do that analysis a little bit easier, especially in patients with very mild keratoconus. Here's a normal eye. Again, the elevation on the front and back with the typical best fit sphere, as well as with the enhanced shape parameters. And basically, you see very little difference between these. They basically look normal on both of them. So this provides you another analysis tool for that reference shape, comparing in a normal eye, comparing the best fit sphere to the enhanced reference shape. Here's the typical display, the Belin Ambrosio display that we use in our practice for looking at patients with refractive surgery. And this gives you several different parameters. It gives you front elevation, back elevation. It gives the float elevation, float information, and then also the front and back differences compared to the normal reference shape. And so again, this is a patient that has keratoconus, and you can see a little bit of, it's barely just right below this, the line on the Pachymetric Progression map. Again, you see the indices down here, and here's the final D is over in this bottom corner showing it's red. So this is a patient that would be one comes in my practice even with a -3 or 4 correction, where I would avoid refractive surgery in this specific patient. So I think this is a good display, a good general display to look at. The other display that we'll oftentimes use is the shape maps looking at elevation and also at the axial curvature. So here you also want to make sure that you get enough data. So anterior posterior surface would typically be able to get 8 millimeters of coverage. And there's actually a little bar up here that says what the diameter is, probably too small to see on your screen, but this diameter here is 8 millimeters. If you have smaller than that amount of information, sometimes that you have to use it with a little bit more judgment. But typically, if you have less information than 8 millimeters, there's also something else wrong with the cornea that you might see on slit lamp examination. Here are those reference, or the numbers basically to look at the several different indices. Again, the final D, I think, basically is a good summary of all these. The hyperope is a different patient, and so when you're looking at the myopic patient in the database that has been done by Belin and Ambrosio to really look at a normal database, hyperopes have a little bit more displacement of their apex, and so a little bit more flexibility, I guess, in the pachymetric progression and the indices. And so you'll want to, there's a box right here that says hyperopic patient or mixed astigmatism. So you want to make sure to click that box if you have a patient that's a natural hyperope or a natural mixed astigmat, because on the normal myopic eyes, the indices are a little bit different. This patient, I think, would be abnormal even if you had to click the hyperopic box. And certainly hyperope or hyperopic patients with keratoconus are a little less common, but I've certainly seen them. And so it doesn't totally exclude the diagnosis of keratoconus. So make sure you're choosing the correct reference box. So select the appropriate reference database. Here's another example. This is a normal eye. So again, you have the front elevation here. In the front elevation, really, nice symmetry, minimal difference between inferior and posterior, a fairly high amount of astigmatism, but it's regular astigmatism. The back elevation, a little bit of difference in the very far periphery between the superior and the inferior section, but really all the values here, +2, +3, +4, in that central paracentral area. Again, good progression from the center to the periphery. On the front, again, the front elevation with the enhanced sphere, very similar. So not much difference really in the coloration there. So that enhanced reference shape, both anterior, posterior, again, looking within normal. And then the front and the back differences, again, show you, very little difference between the various different shapes. And the Pachymetric Progression map, well within the two different lines that basically show you this is a normal eye. And so, lots of useful information in all of these different boxes that we've gone through there. And again, the indices down here, all of them are in the white range. The final D, the kind of the best summary, is also in the normal range or white. So remember, white's normal, yellow, borderline, red, really beware in that patient. Again, this is 0.62, so well below that 1.5, 1.6 cutoff. Here's another eye. Again, this is one where the anterior elevation, both in it looks pretty normal. If you just kind of look at it here in the best fit sphere, enhancement really still looks pretty normal on the anterior surface, but the back surface, and that's where having tomography and being able to use the information that the Pentacam gives you of both the front and the back surface, really shows some back elevation abnormality, and there's quite a bit of difference between the regular sphere, the best fit sphere, and the enhanced best fit sphere. And again, an abnormal pachymetric progression, abnormal D value. Now, not all of them are as clearly normal or abnormal. And again, there's some spectrum that we have to always look at, trying to say, okay, well, was this patient real stable? What's their age? What's their level of correction? Can I maybe do PRK? Should I avoid PRK and LASIK? Should this patient have cross-linking? Kind of where does it fit on that spectrum? And so that's where these maps are useful, but they really still require some clinical judgment, and just all these indices are not necessarily going to give you the answers yes or no for yourself, but they can really give you all that information for you to make a good informed clinical decision for that patient. Now, we've been doing cross-linking in our practice for several years now. And one of the things that I have in the patient with the diagnosis of keratoconus that we're following over time is really, how do we analyze all of the information and data when you're looking at an abnormal map? 6 months later, it's still abnormal, but has it changed? Is it more abnormal? Is it less abnormal? And so there's a new software analysis program on the Pentacam that I think helps to allow you a little bit easier way of doing that, rather than flipping back and forth between a variety of different maps on your images that you've taken with the Pentacam over time. And this is the ABCD progression software. This image here comes from Review of Ophthalmology just this last week. A is basically this bar right here. Kind of the, I guess, peach color on this here. The back surface this is the indice for the back surface, corneal thickness, and then you can actually program in the best corrected vision, and that's this one here. And what you can do is then put up, 2, 3, 4 exams. You basically can pull an exam from 2015, from 2016, from late in 2016, and then, your current one, for example. And you have those indices basically over time. And so, for example, here, the anterior surface is pretty much the same here, 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 and here. So there's really no difference in the anterior surface in this specific patient. The back surface, you can say, okay, there's some change here. Is it a significant change, or is it a change within noise? And they're basically standard deviation bars on either side that are either for normal, and these are in the green, or for a keratoconic eye, because there's a little bit more, just with you and fixation differences, a little bit more of a standard deviation or fluctuation from visit to visit in that group of patients. So there's a range up here. For example, here's the top and the bottom of the range for this patient. And so, this one here may just be short-term fluctuation, but this one here, there's, definite change or definite progression at this time point. And then basically, in a sense, after cross-linking, basically starting to come back down towards normal. So you can follow these patients over time and decide, okay, are they progressing? If they've had cross-linking, are they getting better? Are they progressing again, for example? And those are the questions you want to ask. And so you can look at that information for the anterior surface, the back surface, corneal thickness. So for example, here the corneal thickness went down, went back up again. Again, in the vision. So you can follow all those parameters in a little bit easier fashion than flipping back and forth and trying to understand the information. So we're just starting to utilize this in our practice, but I think it's going to be extremely helpful in following these patients with keratoconus to try to decide if they're progressing, if they're stable, and if we did cross-linking, have they improved, and then again, monitoring them long-term for potentially future progression. Now I'm going to switch from keratoconus to some of the other things that in our practice we think are the real practice needs. And so I've listed several things here: phakic IOL measurements, contact lens fitting. I'm not going to talk much about that, but the curvature measurements are quite useful for that. Intacs, conductive keratoplasty planning, cataract detection, and other corneal imaging. And one of the things that happens, I had two patients come in today, and they're 20 years out after LASIK, and they've got a little bit of mild myopia. They haven't been seen for 10 years. And so the question is, okay, well, what's going on? Or do they just have some regression? If I do a PRK enhancement on them, are they going to stay stable? Is it ectasia? So we've talked about the keratoconus type detection software. Or one of the more common things, a patient was 40, they had their LASIK 20 years ago, now they're 60. Most common in that patient, the reason they're now -75 or -1 is they're starting to develop early cataract. So how can the Pentacam be helpful in that situation? And because we can measure thickness of or densitometry of the lens, we can measure the anterior corneal curvature, we can measure the posterior corneal information, we can look for ectasia, and we can measure this patient when they come in and say, well, when was the last time you had an eye exam? They say, well, 10 years ago. Well, if you're feeling frustrated now and you weren't 2 or 3 years ago, maybe something's changing. So you can document all this information. You get your refraction, you get your slit lamp examination, you get your Pentacam, and then you can track that over time, and you can follow this information over time. So again, here's a patient. It's not one from today, but I had one very similar today, where you're measuring all the information, on the anterior corneal, posterior corneal surface. But here on a dilated fashion, when they say, no, it's just my LASIK that's worn out, you say, no, you've got a cataract. Oh, no, I don't. I can't have a cataract. I'm only 59 years old. Well, here you can show them that extra density in their lens, and this is why they're becoming myopic. And you can, look at it on a scale over here also. And so the ability to document this, to demonstrate it to the patient is really quite helpful by using the shine fluke. So basically, when I look at the slit lamp on the patient, and if I feel like I'm going to have a hard time convincing them, I'll send them back out, have the technician measure a dilated Pentacam, look at the lens, and then basically I can show that image to the patient. So again, here's one different patient, but lens densitometry showing some extra density of the lens in that situation. It does give you a grading scale that I find helpful, but from a demonstration to the patient, I think it's really the scale, tracking that over time, that's oftentimes quite helpful. And there's basically a PNS button down here. You can push the Pentacam nucleus staging button to give you this information. And basically this one is a PNS grade 2. Basically, that's the density of the lens, and it's in comparison to the typical corneal spike in the periphery. It's rated from 0 to 5 as far as the lens opacity for those patients. The other thing is we do a fair number of phakic IOLs in our practice. Again, not a real common use, but enough that you need to have some parameters and know how you're going to utilize or collect the information for these patients. In phakic IOLs, whether it's a Verisyse or a Visian, the anterior chamber depth is quite important. And you could do the anterior chamber depth just based on your slit lamp examination. You could use ultrasound biomicroscopy. You could use OCT analysis. But the Pentacam is actually quite good in the same information that you're collecting the corneal shape information and the back surface information, the tomography, the corneal thickness. You're also getting images of this anterior chamber depth, and there's actually software on the Pentacam that can look automatically at all the different diameters or depths of the anterior chamber in all different angles at each of the different pictures that you're taking. And so we find this very useful. So for example, here's a patient that's kind of borderline for anterior chamber depth if you use just the ultrasound measurements. And there's a fair amount of mid-peripheral rise in the iris that would be, if you are going to use a Verisyse implant, for example, you inclinate it onto the iris out here, but this section of the iris can push on the back of the implant and cause pigment dispersion and posterior synechii. So this degree of mid-peripheral rise in the iris would be problematic from a Verisyse implant standpoint. And then the question becomes if you're going to put a Visian implant behind this iris, is the iris going to be too close to the endothelium? Are you going to have problems with the patient as the lens grows over time? And so we use this preoperatively, but we also use this as the annual screening after we do a Verisyse or a Visian implant. We send them each year, they come back and have speculative microscopy, important to make sure the cells are staying stable, but also then look at this mid-peripheral iris distance between the iris and the angle. George Bykoff, this is an OCT image, but George Bykoff described this 1.5 millimeter safety zone that you want for phakic IOLs. And here's the software that was designed originally for Artisan, or in the US it's called the Verisyse image. And you basically have software that you can select the size and the model of the implant, because the higher myopic implants have thicker peripheral edges. And so it's got software designed to look at this, again, in all of the different orientations. And I think it's very helpful also for Visian planning. We did a series of patients pre and post Visian, and basically the iris moves forward about a half a millimeter. So the numbers were 0.44 millimeters further anteriorly, which is actually the same amount of reduced clearance that you have with a -10 diopter Verisyse implant. So the summary of all that information is that if you have enough room to put in a -10 diopter 6 millimeter Verisyse, then you'll have enough clearance that with the normal amount of iris displacement anteriorly with a Visian, that you'll be safe and won't have problems with plateau iris, et cetera. And so I'll show you, this is just the other one had a little bit smaller version of these images, but here's pre-Visian, and you can see that you have about 2.4 millimeters of clearance here. This is out in the mid-periphery, 2.2 millimeters here, and after your implant, 1.7 millimeters and 1.9 millimeters. And the software actually finds the narrowest section, and it puts it into a reading on the software for that group of patients, so that you know that you're going to have that 1.5 millimeters of safety distance afterwards. I'm going to go fairly quickly through IOL choice for spherical aberration. So, the spherical aberration of the eye itself is a combination of the anterior posterior corneal surfaces as well as the natural lens of the eye. On average, the cornea has optics that are basically oblate, meaning that the optical portion centrally is a little bit more hyperopic than the periphery. The natural lens of the eye, especially the young healthy lens, has a prolate shape, and as you get older, a little bit more of an oblate shape. And so the newer implants that we've been using now for several years, like ASCRS, Tecnis, the, in a sense, quote, modified prolate IOLs, have prolate shape to, in a sense, negate the average oblate shape of the cornea. But not all corneas are the same. And so some patients, I still utilize some of the, in a sense, quote, old implants like the AR40 or an MA60 implant that have oblate optics. And so the question is, with all these different spherical aberrations in various different eyes, you know, which style of implant should you put in? Should you put in a prolate implant? Should you put in an oblate implant? Or should you put in one that has zero spherical aberration? And so how do you utilize the Pentacam to do that? Now, this is a study basically came from some of the data with the Tecnis implant, which has, you know, about minus 0.27 microns of prolate spherical aberration. ASCRS has a little less. And then, you know, the old style implants have oblate optics, and there are implants that have zero spherical aberration. You know, but how do you decide, you know, where in these choices, you know, how do you figure out who the 2% are that have optics such as you should put in, you know, one of the older style implants? How do you decide which ones need the neutral implants, and how do you decide which ones need the prolate modified implants? And you can't really use Wavefront, because Wavefront, like, you know, like on a aberrator or aberrometer that you'd use for refractive surgery, because that includes the optics of the natural lens itself also. So that's not helpful. You need to isolate the cornea. So for example, here's a patient that had, this is the bar for spherical aberration, has negative spherical aberration. This patient, different patient, has positive spherical aberration, but that doesn't give you the story when you're going to take the lens out, put an implant in. It really is useful for other things, but not for that. So the Pentacam has an analysis system that looks at corneal spherical aberration. And there's a box that's right over here that basically gives you the spherical aberration of the cornea itself. And so, for example, here's a patient that obviously has an oblate cornea because they've had previous myopic LASIK. So this is a patient that there's no way that your spherical aberration of your cornea is going to be such that you're going to want to put in a sense, a quote, old style lens or an AR40 or a MA60. So this patient with their oblate optics is definitely going to benefit from the highest prolate IOL that you can possibly utilize. And yet, again, it's helpful numerically to find that information. It's more useful for patients that have eyes that are either prolate or that you're not quite sure about. This is a patient, for example, that's had hyperopic LASIK in the past. And so their cornea is steeper in the middle than in the periphery. So in that patient, the question is, okay, how much spherical aberration do they have? Is it still on the positive side, or is it now on the negative side or prolate side, where I'd want to offset that with, again, I'm calling them old style implants. They're still utilized, but the ones that don't have those new fancy modified prolate optics. And so again, when you print out the Zernike scale on the Pentacam software, it'll give you the number over here, and this patient happens to have negative spherical aberration. And again, you can see why. This one may be a little bit more obvious, even just looking at the shape. But here you have some numerical information to back you up on this, or on patients where you're not quite sure what to do. Excuse me. There are also other cataract printouts, and you can get a lot of these cataract indices all on one page. So you can see the total higher order aberrations. You can see what the regularity is of the topography. So for example, in patients that are having or have astigmatism and will like it corrected at the time of their surgical procedure, it's quite important to try to decide, can I use a toric IOL? And so if they don't have, you know, nice regular astigmatism like this patient here does, then you may not want to use a toric IOL. And you can also compare the astigmatic information for the front, the back corneal surface, and get total corneal toricity by utilizing this cataract type pre-op information. So here's just a blown up view of this section here. So you've got the total corneal spherical aberration is basically plus 0.179 microns. So this is a patient that, for example, would do very well with an ASCRS or a Technis modified prolate optics. This one here, based on the fact that it's 0.17, that's about exactly what the prolate aspect of the ASCRS implant is. If you had a patient that was 0.27 or 0.28, that might be a patient that would be better off with the Technis series implants that have a little bit higher spherical aberration. It also gives you the total corneal astigmatism. So you basically have the total corneal astigmatism up here. This is the back corneal astigmatism, -4 diopters at 72. But you have these indices that can basically help you by looking at the corneal astigmatism also. So here's just a different view of the astigmatism. So you've got the Simcase, which is just the anterior surface, showing 3.4 diopters of astigmatism with a steep axis of 164. But here's the total corneal refractive power that shows 3 diopters at a slightly different axis of 79. So this information is quite helpful in planning a toric IOL because you can actually directly measure this total corneal refractive astigmatism in this specific patient here. So here it's 3 diopters for the total cornea with a steep axis of 169 degrees. And astigmatism correction at the time of cataract surgery is quite important because over 70% of patients have a half a diopter or more of preoperative astigmatism. And if we don't address that for good uncorrected vision, then our patients are dissatisfied, especially if they want an uncorrected target post-operatively. And so we do astigmatic measurements and use corneal topography, tomography, in all the patients having cataract surgery where they desire correction of their astigmatism at the time of the surgery. And a big part of it is trying to detect, is it regular or irregular astigmatism? And then the other part is how much total corneal astigmatism do they have, and how do I address that? A toric implant, what type of toric implant, how do I orient it, etc. Or is it asymmetric enough? I need to say, no, I can't use anything to correct toricity, or maybe I could use a limbal relaxing incision or astigmatic keratotomy, or maybe they're better off with postoperative PRK or LASIK after the procedure. So here's a patient, for example, that had a toric IOL, and they came to me and basically, so I'm not very happy with my toric IOL. And so they have a SN6 AT5 that's oriented at 150 degrees. And here's their refraction, -2 + 3. Best corrected is only 20/40. So we did the topography on a bunch of different ways, Wavescan, Pentacam, Humphrey. We came up with a bunch of different answers. And if you look at their Pentacam measurements, you can tell why. They've got very irregular astigmatism. This patient actually had previous radiokeratotomy. But you look here and you say, well, gosh, I'm not sure. You know, even though these will find astigmatism and they'll put it at a specific axis on the, quote, Simcase, if you look at the pattern of the mapping, the patient has quite irregular astigmatism. John Berdahl, one of my fellows in the past, and I designed this website called astigmatismfix.com to try to help with looking at patients that are unhappy with toric IOLs and trying to figure out, can you improve it by rotation of that implant? And obviously in that prior case, there's no way that you can find the right axis to rotate an implant to. And that's basically what this shows you. If you rotate the toric based on the refraction, when you calculate it through astigmatismfix.com, if you rotate it to the best axis, or 115, you still have a diopter of astigmatism. If you rotate it based upon the wave scan, you still have 1.45 diopters of astigmatism. If you, and I didn't put the information up here, but if you rotate it on the Pentacam, still about a diopter of residual astigmatism. And so this type of a tool can help you figure out where to rotate it if it would be helpful. But the Pentacam basically gives you the information that you said, that's too irregular. There's no way I can rotate that implant and actually have a good result. Here's another example of management of regular astigmatism. So we basically look at the anterior sagittal curvature measurement on this patient here. And this patient has very regular astigmatism, but they still ended up with almost 2 diopters of astigmatism at axis 150 after placing the toric IOL into the patient. And actually going backwards, it would have been closer looking at it with the total corneal aberration. That's what I use now. Today is using total corneal astigmatism with the Pentacam, but at that point we were told to use anterior Ks, and so we basically used anterior measurements only. But this patient, when you put them into the astigmatismfix.com, basically suggests moving the axis from where it's currently at 108 degrees to 120 degrees, or 12 degrees counterclockwise. And actually the beauty of going back post-operatively and doing the measurements is you're not really dependent upon head tilt. You know where the implant currently is, and you need to move it 12 degrees in this situation counterclockwise. Now, they don't move very well counterclockwise. You actually have to spin it clockwise. But I'll walk you through the steps of the procedure here. Now, this is an Acrosoft implant, so a little hard to free up in the periphery, but typically, even out to a few months, you can free up the implant and then basically rotate it to get it free, get it close to its desired axis. And again, here we're moving it not necessarily to a new spot, but 12 degrees away from its old spot by intraoperative marking for that patient. This patient happened to be a fairly high myope, so real careful viscoelastic removal from behind the implant afterwards, and then basically you can put it at its new orientation at at 120, but it's really 12 degrees different from where it is, because it's really hard to measure, decide that you're at 108 or 110 or 115. So that's the beauty of using this astigmatismfix.com software. So using the Pentacam, I found very helpful with toric planning. Again, there's some good references or data out there, but by using the total corneal astigmatism, you take into consideration some of the fudge factors that are built into some of the newer software programs like the Barrett Toric calculator, etc. But using that total corneal refractive power is very, very helpful. And it calculates that total corneal refractive power, and it uses anterior posterior corneal shape, corneal thickness, and Snellen's laws of refraction. So that's why you can get a little bit extra accuracy with your toric IOLs by utilizing the Pentacam. So, here, for example, the anterior axial power is at 14, total corneal refractive power is at 16. Small difference, but again, especially in these high astigmats, that couple of degrees can be very helpful in improving your data and your results. We've also used the Pentacam for post-LASIK calculations, again, looking at mostly true net power. And this is part of what's included now in the ASCRS calculator website for post-LASIK PRK data. And there you're better off just plugging in the information, and you get that as part of your portfolio of data or information. So in conclusion, Pentacam, not just only for keratoconus screening, although in our practice a lot of that is what we do, but we use it a lot for our lens-based patients. For phakic IOL planning, as I showed you, we're able to track and follow these patients over time to make sure they've got a safe clearance between the mid-periphery and the endothelium. We can know whether it's safe to put in a Verisyse or a Visian implant. Again, with the Visian implant, which is probably 95% of the use of phakic IOLs in the US, the average anterior movement is about a half a millimeter. That's the same as the, in a sense, anterior reduction in clearance of a Verisyse minus 10 diopter implant. So you can use that phakic IOL planning for that. And then you can use it for IOL planning, spherical aberration, and also for toric IOLs using the total corneal toricity or total corneal astigmatism. So I want to thank you for your attention tonight, and wanted to say we've still got 10 minutes or so here for some questions. So I'm happy to answer questions if you want to type them in there, and then Chris will read them for us. Again, I appreciate your attention tonight, and I'm happy to stay around here and answer any questions that you might have.
Well, thank you very much for the very interesting presentation and for sticking around for questions. And it's been a pleasure having you, Dr. Hardten. And thank you, everybody else out there, for attending another Oculus Clinical Webcast.